The management of sigmoid volvulus, a comprehensive podcast discussion. Welcome to today's episode of the Everything Surgery podcast, where we will be dissecting the management of sigmoid volvulus. Our aim is to provide a clear, thorough, and engaging exploration of this surgical emergency, guiding you step by step through clinical assessment, diagnosis, and treatment strategies. Understanding sigmoid volvulus. Sigmoid volvulus is a critical condition that arises when the sigmoid colon twists around its mesentery, leading to a closed-loop bowel obstruction. This can quickly become life-threatening due to the risk of compromised blood supply, bowel ischemia, perforation, and ultimately, death if not addressed with urgency. Management of this condition requires a systematic and well-structured approach. Clinical presentation and diagnostic evaluation. Let us begin by outlining the typical patient profile for sigmoid volvulus. It frequently presents in older male patients, often with significant underlying medical conditions such as neurological or psychiatric disorders, and a history of chronic constipation. Many patients are residents of long-term care facilities. The classic symptom triad includes sudden, intense abdominal pain, marked abdominal distension that may be asymmetric, and absolute constipation, characterized by the inability to pass stool or gas. However, it is important to note that not all patients will display this triad. For diagnostic evaluation, a plain abdominal X-ray remains a valuable tool. It typically reveals a massively dilated, smooth-walled sigmoid colon, sometimes described as resembling a bent inner tube or coffee bean, with the apex of the loop pointing toward the right upper quadrant. However, the most definitive diagnostic modality is the computed tomography scan of the abdomen and pelvis. This imaging not only confirms the twisted bowel and associated whorl sign but also helps exclude alternate causes of obstruction and identify signs of bowel wall compromise, such as air within the wall or free air indicating perforation. Stepwise approach to management. Management of sigmoid volvulus is dictated primarily by the patient's clinical stability and the presence or absence of peritoneal signs, which suggest bowel ischemia or perforation. Let us walk through the management algorithm in detail. Initial resuscitation and assessment. Every patient must first undergo thorough resuscitation. This involves securing the airway, supporting breathing, and ensuring adequate circulation. Vigorous intravenous fluid administration is essential to correct dehydration and any shock. A nasogastric tube should be placed to decompress the gastrointestinal tract, and broad-spectrum antibiotics are administered to target gram-negative and anaerobic organisms, commonly using agents such as third-generation cephalosporins and metronidazole. It is also critical to correct any electrolyte imbalances at this stage. Urgent intervention. The decision point. The pivotal question is whether there are clinical signs of peritonitis, sepsis, or bowel perforation. If these are present, non-operative management is not an option. The patient should proceed directly to emergency surgery. The standard operation involves resection of the affected segment of sigmoid colon, with the creation of an encholostomy, a procedure known as Hartmann's procedure. In these cases, primary anastomosis is avoided due to the high risk of leakage into a septic and unprepared colon. If the patient does not exhibit signs of peritonitis and is otherwise stable, the goal shifts to non-operative decompression and detorsion as an interim measure. This is achieved using endoscopic techniques, either with rigid proctosigmoidoscopy or flexible sigmoidoscopy. The scope is advanced gently to the side of the twist. Successful detorsion is often marked by a sudden release of gas and fluid. A soft, lubricated flatus tube is then inserted through the scope and secured in place for 24 to 48 hours. This tube allows continued decompression and helps prevent immediate recurrence by splinting the bowel. Definitive management. Elective surgery. It is vital to understand that non-operative decompression is only a temporary fix. Recurrence rates are alarmingly high, ranging from 40 to 90%. Therefore, elective surgical resection of the sigmoid colon is considered the standard of care to prevent further episodes and reduce the risk of mortality. This definitive procedure is usually scheduled during the same hospital admission. Once the patient is medically optimized and the bowel is adequately prepared, the operation of choice is elective sigmoid colectomy with primary anastomosis, which involves removing the redundant sigmoid colon and connecting the descending colon to the upper rectum. This approach eliminates the site prone to volvulus, avoids the need for a permanent stoma, and can often be performed laparoscopic, resulting in less post-operative pain and faster recovery. Special considerations. It is important to distinguish sigmoid volvulus from cecal volvulus. as the latter rarely responds to decompression and almost always necessitates a right hemicolectomy. In patients deemed too high risk for major surgical intervention, endoscopic decompression with a retained flatus tube may be the only feasible option, though recurrence remains a significant concern. A percutaneous endoscopic colostomy has been described as a less invasive alternative, although it is not widely practiced. Summary of the management strategy. To recap, the management of sigmoid volvulus involves several key stages. First, resuscitate the patient with aggressive intravenous fluids, nasogastric decompression, and antibiotics. Second, differentiate based on clinical signs to identify those requiring immediate surgical intervention. Third, decompress the bowel non-operatively if the patient is stable and the bowel is viable. Fourth, plan for definitive resection with elective sigmoid colectomy to prevent recurrence. Lastly, in cases of non-viable bowel, perform emergency resection with Hartmann's procedure. This structured, multi-phase approach ensures both immediate relief of obstruction and a long-term solution to the underlying anatomical predisposition for volvulus. Thank you for joining us on this episode of the Everything Surgery podcast. If you found our discussion valuable, please like, share, and subscribe to stay updated with more insightful surgical content.